Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I'm pleased to welcome you to the multimedia summary of the journal's December 2018 issue. There are 4 articles this month that have been selected as our Editor's Choice or Highlight articles. Our Editor's Choice is an original article entitled Various Leisure Time Physical Activities Associated with Widely Divergent Life Expectancies, the Copenhagen City Heart Study. This is authored by Dr. Peter Schnoor from Frederiksberg Hospital, Copenhagen, Denmark, and colleagues affiliated with medical centers in Denmark, the United States, and Australia. Substantial evidence over the past 60 years has shown that physical activity reduces the risks for coronary artery disease and all-cause mortality. Different types of physical activity, including various types of sports, require markedly different intensities and durations of exercise, different muscle groups, and variable amounts of dynamic and static muscle contractions. It is possible that they confer different effects on longevity. The present study evaluated improvements in life expectancies associated with participation in various sports. The Copenhagen City Heart Study is a prospective population study that includes detailed questionnaires regarding participation in different types of sports and leisure time physical activity. In the present analysis, close to 9,000 participants were followed up for 25 years for all-cause mortality from their examination between October 1991 and September 1994 until March 2017. Relative risks were calculated using Cox proportion hazards models with adjustment for confounding variables. The results demonstrate that multivariable adjusted life expectancy gains compared with the sedentary group rounded to the nearest year were, for the various sporting activities, as follows: tennis 10 years, badminton 6 years, soccer 5 years, cycling 4 years, swimming 3 years, jogging 3 years, calisthenics 3 years, and health club activities 2 years. The large differences in life expectancy gains were not accounted for by differences in the duration of the various sports, as highlighted by the finding that the cohort of people who spent the most time exercising, such as health club activities group, was the one that showed the smallest improvement in longevity. The authors conclude that various sports are associated with markedly different improvements in life expectancy. Interestingly, sports that require 2 or more individuals to play together and socially interact, specifically tennis, badminton, and soccer, were the sports associated with the best improvements in longevity, whereas the less interacting activities, such as jogging, swimming, cycling, and health club activities, were associated with less impressive longevity benefit. Belonging to a group that meets regularly promotes a sense of support, trust, and commonality, and has been shown to contribute a sense of well-being and improve long-term health. This effect may underlie the better longevity for those sports that inherently involve more social interaction. Our first highlight is an original article entitled New Onset Diabetes and Pre-Existing Diabetes are associated with comparable reduction in long-term survival after liver transplant, a machine learning approach, and it is authored by Dr. Venkat Bhatt from the University Health Network in Toronto, Ontario, Canada, and colleagues from Mayo Clinic, Rochester, Minnesota. Survival after solid organ transplant has significantly improved over time. However, the long-term quality and quantity of life of recipients may be adversely affected by complications, including diabetes and obesity, which impose a higher risk of cardiovascular disease. Weight gain after solid organ transplant commonly occurs, resulting in insulin resistance and metabolic alterations. New-onset diabetes mellitus after transplant occurs in up to 25% of liver transplant recipients. The present study sought to identify key predictors and survival outcomes of new-onset diabetes after transplantation in liver transplant recipients using the Scientific Registry of Transplant Recipients. Data of all adult liver transplant recipients between October 1987 and March 2016 were analyzed using various machine learning methods. The key advantage of the machine learning method over the traditional predictive model is that machine learning involves an iterative process, namely, learning from existing data to find patterns among variables and accordingly modifying the model. Machine learning-based methods can yield novel hypotheses which require validation in separate data sets and integration with domain expertise. Data so derived in this study were divided into training 70% and validation 30% data sets respectively to determine predictors of new onset diabetes after liver transplant. The results demonstrate that increasing age, male sex, and obesity were significantly associated with new onset diabetes after liver transplant. Donor features do not affect risk. Sirolimus, as a primary immunosuppressant, carried a higher risk of new onset diabetes after liver transplant than did tacrolimus at 1 year after liver transplant. Most notably, patients with new onset diabetes after liver transplant had significantly decreased 10-year survival as compared with those without diabetes, and this was similar to survival rates in patients with diabetes before liver transplant. Based on this adverse effect of new onset diabetes after liver transplant, the authors emphasize the need for more aggressive care and closer follow-up. The second highlight is a brief report entitled Association of Low Urinary Sodium Excretion with Increased Risk of Stroke by Ms. Liana Kineka and colleagues from the University of Groningen, the Netherlands. The positive relationship between sodium intake and blood pressure is well established. There is also strong evidence that a high sodium intake, greater than 8 grams per day, is associated with an increased risk of cardiovascular disease, and that the reduction of such excess sodium intake to moderate amounts lowers the risk of cardiovascular disease, including ischemic heart disease and stroke. However, there are several studies indicating that the reduction of sodium intake below 3 grams per day may be associated with an increased risk of cardiovascular disease. Such studies and the absence of data indicating that reducing sodium intake to low levels decreases the risk of cardiovascular disease have led to the assumption that there may be a J-shaped association between sodium intake and cardiovascular disease. Since high blood pressure has a prominent role in the risk of stroke, it may be anticipated that an increased sodium intake confers a higher incidence of stroke. However, the literature regarding the association of sodium intake with stroke risk discloses quite divergent findings, including overall positive associations only in certain subgroups, null associations, and a J-shaped association. These inconsistent findings may reflect, at least in part, the fact that such studies largely rely in dietary questionnaires or spot urine samples to assess dietary sodium intake. Both methods are much less reliable measures of sodium intake as compared with the gold standard, namely urinary sodium excretion measured over 24 hours, the latter employed in very few studies. Ms. Kineka and colleagues examined the association of urinary sodium excretion with the risk of stroke in more than 7,000 individuals free of cardiovascular disease at baseline in the Prevention of Renal and Vascular End-Stage Disease Study, PREVENT study, a prospective population-based cohort of Dutch men and women. Urinary sodium excretion was measured in two 24 urine specimens at baseline in the years 1997 and 1998, and 2 specimens during follow-up in the years 2001 and 2003. Baseline median urinary sodium excretion was 137 millimoles over 24 hours. During a median follow-up of 12.5 years, a total of 183 stroke events occurred. A significant inverse association between urinary sodium excretion and the risk of stroke was observed after adjustment for age and sex, with a hazard ratio of 1.36 for 1 standard deviation of decrement of sodium excretion, 50 millimoles per 24 hours. which remained independent of adjustment for anthropometric, dietary, lifestyle, and other possible confounding factors. After adjustment for potential mediators, systolic blood pressure and antihypertensive medications, plasma renin, aldosterone, and sodium levels, the association of urinary sodium excretion with the risk of stroke remained unchanged, with hazard ratios of approximately 1.5. This study thus reveals an association of low urinary sodium excretion and, as a corollary, low sodium intake with an increased risk of stroke. The basis for these findings is uncertain. Low sodium intake leads to increases in serum levels of cholesterol, renin, aldosterone, and triglycerides, and catecholamines, which, in aggregate, may accelerate atherosclerosis and induce vasoconstriction. Adjustment for cholesterol, renin, and aldosterone in this study did not affect the relationship between sodium intake and the risk of stroke, which leaves open the possibility that catecholamine-induced vasoconstriction or increased triglycerides may play a role. Possible limitations of this study include the fact that this study involved largely normotensive individuals with a healthy weight. Thus, the extent to which these findings pertain to the risk of stroke in patients with hypertension and other risk factors is uncertain. Additionally, issues pertaining to reverse causation and/or residual confounding may be relevant. These intriguing findings call for additional studies that determine whether an adequate sodium intake could possibly lower the risk of stroke. The third highlight is an original article entitled Time Trends and Outcomes After Aneurysmal Subarachnoid Hemorrhage Over the Past 30 Years by Dr. Biagio Lapira and colleagues from Mayo Clinic, Rochester, Minnesota. During the past 3 decades, the management of aneurysmal subarachnoid hemorrhage has markedly changed. Early treatment of a ruptured aneurysm has decreased the incidence of rebleeding, and the development of coiling has provided a valid alternative to clipping. Additionally, progress in neurocritical care and a better understanding of the pathophysiology of delayed cerebral ischemia have served to minimize ischemic sequelae. However, little information exists regarding the effects of these advances on overall outcomes in patients with aneurysmal subarachnoid hemorrhage. The present study analyzed trends in mortality rates, functional outcomes, and treatment in patients with aneurysmal subarachnoid hemorrhage over the past 3 decades. The authors conducted a retrospective review of consecutive patients with aneurysmal subarachnoid hemorrhage treated at a single tertiary center, Mayo Clinic, Rochester, Minnesota, between January 1985 and December 2014. 1,173 patients were identified and grouped by decade of treatment, the first decade being 1985 to 1994, the second 1995 to 2004, and the third 2005 to 2014. Overall, the use of endovascular techniques increased progressively from 5% to 66% from the first to the third decade. This was paralleled by a progressive decrease in the rate of clipping from 79% to 22% from the first to the third decade. The percentage of patients admitted with poor clinical grade also increased from 22% to 24% to 30% over the 3 decades. The in-hospital mortality rate decreased from 27% in the first decade to 16 to 17% in the second and third decades, and good functional outcome at 3 months to 6 months follow-up improved significantly from 65% to 79%. The authors conclude that outcomes in patients with aneurysmal subarachnoid hemorrhage have markedly improved over the past 3 decades in terms of both in-hospital survival and functional recovery of survivors. Higher rates of endovascular coiling over time parallel these improvements in clinical outcomes. More detailed investigation is necessary to determine whether this or other factors may directly explain the favorable trends in survival and functional recovery over time. You can access these highlights and editor's choice articles free of charge during the entire month of December. When you visit our Mayo Clinic Proceeding website at www.mayoclinicproceedings.org, you will find links to our social media by clicking the buttons at the top of the home page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find author interviews, 60-second video article summaries, and our Mayo Clinic Proceedings fireside chat recordings, which are available from our website on the home page, as well as through iTunes. You can also find our Pioneers and Legends video interview currently featuring Dr. James Dick. On our website, you'll see many news stories that are based on articles published in Mayo Clinic Proceedings. And finally, you'll see other free content and articles published online ahead of print. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.